Bom dia. Good morning. My name is Vania and I'm a third-year resident of family medicine of your neighbor ULS/Mondego. And I was challenged to come here today to talk about optimizing osteoporosis screening and treatment in primary health care. If during the presentation I'm not very clear, please interrupt me, that I'll try to explain better. So osteoporosis is a silent disease until the fracture occurs. But when the osteoporotic fracture occurs, it is already late because the morbid mortality increases a lot. These fractures occur usually in spine, hip or wrist and reduce a lot the quality of life of our patients. But not only of our patients, also their caregivers. They will need caregiver support, they will need hospital and rehabilitation, and these all involve costs. So because of the greater expectancy of life, because nowadays we live more, this disease has an increased prevalence nowadays with all of the consequences that involves. So we have to face it as a public health problem, and us in primary health care, we have to focus on that. But in primary health care, as in the hospitals, we have time constraints. And not only, we feel sometimes that we have insufficient knowledge, we have doubts about treatment's effectiveness, and fear of adverse effects. And also our patients sometimes are not available and ready to start this new therapeutic because they have fear too. Osteoporosis can be defined in two ways, by DEXA and through the clinic. And this is very important to be aware of. Because, as I put in the green box, did you know that more than half of the people with fragility fractures did not have an altered DEXA scan? This is really important to be aware of. So, two questions, just to understand what is your reality, if it's the same as mine. Who feels that insufficient time is spent on diagnosing and managing osteoporosis? No, we pay as much attention to osteoporosis as we do to diabetes or hypertension. Yes, there's not enough time. Okay, we share the same opinion. It's the same. And now, why do you feel the osteoporosis screening doesn't get enough attention? Because we have time constraints? Because we don't have enough knowledge? Because we have doubts about treatment's effectiveness? Or we have fear? Okay, I think it's all of them. And in Portugal, in 2018, only 25% of women with osteoporosis received treatment. And these numbers are very frightening, and we have to change this. We have to stop this gap treatment because the numbers, and in the near future, we know that the probability of fractures will rise. So, in primary, the crucial role of primary care, what we do the best is prevention. So we have to do it. Mainly the primary prevention, how? Recommend a healthy diet, recommended Q8 sun exposure, and weight-bearing exercise in all stages of life. We have to increase population's health and self-care literacy, as Professor Glenn was saying. We have to increase professionals' knowledge and identify the patients who are in risk through the FRAX, as Professor José Silva said. After the fracture occurs, we can prevent also through the secondary prevention, and this is also really important because in first year after the fracture, the patient will have 2 to 5 times a higher risk of recurrence. But we are not doing the follow-up of these patients in a correct way. And why? because we don't have a specialty that dedicates and is responsible for this problem, for this disease. We have to give a response to this problem. That's why nowadays we start to talk about post-fracture care, and this is a very important concept. What is this? It is a multidisciplinary team with nurses, with rheumatologists, with primary care providers, with orthopedic surgeons, pharmacists, nutritionists that will help manage the patients with osteoporosis and that have already a fracture. This is not our reality in Portugal, but I hope that what we are doing this today is running in this direction. I can give you my lucky experience, okay? I work in a primary health center, but when I have doubts, and I was talking to that with Dr. Mary, when I have doubts, I have the luck and facility to call to my colleagues. Usually I call to rheumatologist service, and they are very accessible. They help me. They give me 2 minutes of their day, helping me to manage in the best way the cases where when I have doubts. So this is really good. Steps to manage osteoporosis and prevent disability in primary health care. Step 1, we have to identify at-risk patients. This is really, really important. Step 2, investigate and diagnose patients with the disease. Step 3, intervene with personalized treatment plans. Step 4, implement long-term monitoring and re-evaluation to minimize the fracture risk. Step 1, identify. We have to identify clinical risk factors of this disease and fragility fractures throughout the life. And the risk of fracture should be regularly assessed in all patients over the age of 50. We have non-modifiable risk factors and modifiable risk factors, and the modifiable ones are those that we have to change, because if we can change that, we can change also the course of the disease and, of course, the prognosis of it. Step 2, investigate and diagnose. Through FRAX, Professor José Silva had already talked about this. This is a fracture risk assessment validated to Portuguese people that estimates the individual probability of fracture risk at 10 years. This is available online. We have to change the country where we are to calculate correctly, and then we can do it with or without DEXA, and we have to fill the empty space that are related to risk factors, yes. And this is really good because it can help us to decide, okay, I must do DEXA, I must start the treatment, and it's really helpful. But it has also constraints. It doesn't consider type and number of previous fractures, dose and duration of corticoid treatment, vitamin D values, risk of falling, only allows the insertion of DEXA values of the hip, and is poorly suitable for some causes of secondary osteoporosis. DEXA can give a bone mineral density, okay, and is warranted when FRAX without DEXA give us a value between 7 and 11% for major osteoporotic fracture and between 2 and 3% for hip fracture. When we have postmenopausal women aged 65 years and above, men over 70 years, patients with risk factors for osteoporosis not included in FRAX, to study secondary osteoporosis and evaluate the efficacy of interventions. And this is a figure that demonstrates that I've just said. Also, it is important to say that we must do lateral spine radiographs when we identify patients suspected of having vertebral fractures. Those are the ones that have complaints about prolonged or unusual back pain, loss of weight superior of 2 centimeters, increased occiput to wall distance, and kyphosis. And we should also evaluate factors that increase the risk of falling, gait abnormalities, balance problems, and decreased ability to perform the timed up and go test. Step 3, intervene. How? First of all, and always must be present, non-pharmacological preventive measures, healthy diet, exercise, adequate calcium intake, and intake of vitamin D. As Professor said, we must only supplement if we don't have the right levels. And avoidance of excessive alcohol intake and smoking, and also, and very important, preventive falls. Pharmacological treatment is initiated, if is not contraindicated, when we have one or more of the following criteria: more than one fracture of the hip or more than one symptomatic vertebral fragility, fracture, more than 2 fragility fractures, independently of the site or the symptoms. FRAX give us, without DEXA, a value above 11% for major osteoporotic fracture, or more than 3% for hip fracture. Or if FRAX give us with DEXA a value above 9% for major osteoporotic fracture, or above 2.5% for hip fracture. And this is, in a scheme, in a figure, what I've already said. The first line pharmacological treatment is oral bisphosphonates, mainly oral alendronate, because it's the most cost-effective. But we have another options: intravenousal andronic acid and denosumab in case of oral intolerance, malabsorption, dementia, non-compliance. Denosumab is really helpful in the case of renal insufficiency, and teriparatide has high costs, but is really good for those who has a very high risk of subsequent fractures. Here I made these tables. I'm not entering details because Professor explained much more than me about this thematic, the drugs, but I give you this information for you to assess and study if you wish. And at least step 4, implement long-term monitoring. We must reassess annually clinical risk factors, occurrence of fractures, body height, and adherence to lifestyle interventions and medications. Only doing this evaluation, we can understand if our measures are being implemented and well implemented. DEXA should not be repeated within less than 2 years, unless the risk factors changes. And the drug holidays only is considered for bisphosphonates. We can interrupt it for 2 or 3 years if the 3 following conditions are verified. The treatment has been strictly adhered for at least 5 years with oral or 3 years with intravenous bisphosphonates. No fragility fractures occurred under the treatment, and femoral T-score is above -2.5. The main goal of these drug holidays is to prevent a typical fracture. But if we do the drug holidays, we must reevaluate regularly the patients. So now this is the main question. What can we change to be more aware of this problem? I've said already that we are aging, we live more nowadays. This disease has a lot of consequences, but still is underdiagnosed and undertreated. What can we do? Primary health care is the first contact of the patients with health system, and we have a critical role in improving osteoporosis management and closing this treatment gap. So what I propose is to adopt a systematic approach to proactively screen patients, increase the population and health professionals' literacy. This is really, really important. Work as part of a multidisciplinary team with other medical specialties and professionals. Fight therapeutic inertia and improve clinical records. Thank you.